Hello, everybody. My name is Valeria Caso. I'm a stroke neurologist from Italy. I'm the former president of the European Stroke Organization, and I'm very happy and I'm very thankful for the organizer for inviting me to speak about something which we all felt in the last 2 years, the impact of the COVID-19 pandemic on stroke care. I'm here not alone, you can imagine. I'm here with a wonderful panel. You see already the name. They do not need any kind of special introduction. We have Dr. Pandyan Jariash from India. We have Dr. Peter Panagos from US and Giselle Sampaulo Silva from Brazil. You see, we have a very broad coverage of the different scenarios that we have been gone through. And we discussed many times among each others about these, how to maintain very high the attention to stroke care. So before starting, I want to say that nobody of us has no disclosure for the talk. Here you can see all the disclosures. Next, please. So I have to share with you some housekeeping notes. You know, you have the possibility to send some questions in the question and answer box. You can also use the box to say hello or leave your feedback, participate in the polls. It's very important. We also need that you complete your evaluation survey, because it's for us very important, and also for the one who comes after us, to improve what we can offer to you as listeners. And it's not so much, we hope to have it very interactive. So we want you to really be active part of this webinar. This webinar will be recorded, so it will be available on demand. So at the conclusion, what we wish and what we think together with this, I really believe that we really do not know how much is the impact of COVID pandemic on the stroke system of care. So we did a lot of effort to maintain. And you will also review the low cost, high impact recommendation commonly practiced globally to sustain stroke care. You know, stroke care, we always think about stroke care having high technique, high impact MRI, but stroke care is us, our skill, our knowledge on stroke patients. And it's something that we always need to remember. Next, please. So, and you see this paper, this was done especially by Dr. Pandyan. So he really involved us in writing these papers about the maintaining stroke care. And again, it gives us an overview on what has been done, and also you will find some suggestion. And I strongly invite you to read this paper, because it's you will feel what happened, what we went through, everybody of us and our colleagues, and it's also important because we think that every year we hope it's over, but we do not know if it's over, and we need to adapt to this, what we always call the new normality, and to have some guidance also in this. I think it will be almost very helpful. So let's go to the first speaker. So we will start with Asia. So Dr. Pandya will start, and he will speak about the impact. We all remember. I think I will never forget about what I saw about the impact of COVID-19 in India, and I think you really did a wonderful job to maintain highly the attention to stroke. Thank you.
Yeah, thank you, Dr. Caso, for the introduction of the topic. And so what I'm going to do is just to give a quick overview of what was the impact in Asia and some of the important nations like China and India. These are the two countries severely affected by COVID-19 pandemic. And overall, in most of the countries in Asia, there was a disruption in the healthcare system because of simultaneously they had to cope with the increase in number of COVID patients and also try to cater to all the other diseases as well, particularly non-communicable diseases like stroke and cardiovascular diseases. So there were a shortage of beds in most of these countries, and India, and particularly during the second wave, when we are not prepared, there was a shortage of oxygen supply in hospitals. Many patients died because of lack of oxygen supply to the hospitals. And indiscriminate use of non-approved drugs, even though the governments had issued guidelines, but people were using steroids even for very, very mild cases. And as a result, what happened was in India, there was a rise in mucormycosis cases. It was rampant, and there was shortage of medications to treat mucormycosis, like amphotericin, etc. And in the pre-hospital care, the most important thing that happened was diversion of the ambulance services wherever it was existing to take care of COVID-19 patients. And of course, in many countries, this was noticed that there was reallocation of stroke unit beds. Stroke unit beds were taken off and they were given to the COVID area. And in addition, there was a disruption of acute stroke care and rehabilitation services. And the most important thing is that the early phase, the early phase of first wave, and then in the second wave, there were a lot of shortage of PPE kits. And next slide, please. And in terms of numbers, stroke numbers, this is a multi-center study from India where we found that there was a decrease in number of stroke admissions. And also it reflected on the decrease in number of intravenous thrombolysis and mechanical thrombectomy, almost 50 to 60% reduction. And in the later part of the lockdown, the numbers, the IVT numbers and the mechanical thrombectomy numbers started increasing. And a similar impact we saw in the second wave as well. There was some drop, and then it started increasing, which reflects on how the healthcare system adapted to the sudden surge in these cases. Next slide, please. In China, again, we see a similar phenomena, 20 to 50% reduction in stroke admissions, and the patients were less likely to receive stroke unit care, reduction in thrombolysis, thrombectomy, and it was particularly seen in the worst affected region like Wuhan, and also in other regions of the country. Next slide, please. And this is one survey that we did in the Asian Stroke Advisory Panel. About 9 countries that participated, and we sent the questionnaire to all the members of this Asian Stroke Advisory Panel. And what we found was there was a disruption in emergency services and evaluation of patients in the emergency department. There were changes in terms of management of patients in the stroke unit and acute care, thrombolysis, mechanical thrombectomy. And there was an increase in usage of telemedicine, telestroke, and also it affected the community care of stroke patients. So in Asia, if you look at not only India and China, but also in other Asian countries, there were disruption in stroke services, reduction in number of stroke patients, and intravenous thrombolysis, as well as the mechanical thrombectomy. Next slide. So how did these nations maintain the stroke care? And what are our recommendations, which we have covered in the position statement? If you look at the pre-hospital care, the patient should reach as early as possible, whichever conveyance they can use. If the ambulance is available, they can use that. Otherwise, they can come on their own conveyance. Use of activated protected stroke code. Each center should have a written protocols for CT scan and MRI scan, and also a protocol for disinfection after each scan, and protocols for IV thrombolysis. And there has been many places where people have used tenecteplase because of the convenience of using it, and avoid the exposure to COVID positive patients. And if you're looking at endovascular treatment, proper PPE should be used. Ideally, a sedation during procedure would be better as compared to giving general anesthesia. In the stroke unit, you can modify whatever that are existing, still try to maintain the care bundles like a fever swallow and sugar, the FEST protocol. Limited rehabilitation you should look at, so that there is no long exposure of rehab specialists to the patient. Telestroke is the best way to do. And in some Asian countries, they have used mobile stroke unit to triage patients instead of taking them to the emergency department. And stroke robot in Thailand, where the robots were used for screening these patients. So with that, I'll conclude the impact of COVID-19 on stroke care in Asia. Thank you.
Thank you. Thank you. Now it's my great pleasure to ask Giselle Sampaolo Silva to continue. And I think also another continent that had a big fight with COVID was Brazil, part of the South American continent. So, and I think what I heard you did as well, a wonderful job in maintaining what we call the stroke care. So Giselle, thank you very much.
Thank you very much, Valeria. It's such a great pleasure to be here with you. I'm really honored to speak about the impact of COVID-19 in my country. So you can go to our next slide. So it was a coincidence that when we had the first case of COVID confirmed in Brazil, it was actually confirmed in the hospital that I work at, Albert Einstein Hospital, a tertiary care hospital in São Paulo. We are actually having what we call the Global Stroke Alliance meeting. It happened to be probably the last in-person meeting that you have for stroke in our country. And I guess that it was a coincidence, but because we didn't imagine at that time that would be facing such a great challenge of taking care of patients with stroke in the setting of COVID-19. We can go to the next slide. You can see that in Brazil, actually our healthcare system was really impacted by COVID. When in the first 15 weeks of the first diagnosis of COVID, this publication was issued when they compared the admission due to acute respiratory syndrome, comparing 2019 and 2020, when we had the first case of COVID-19. So we are actually comparing the impact of influenza and COVID. And you can see the cumulative cases and the number of cases admitted to intensive care units because of COVID. So this was a huge impact. And I am really glad that Jayrad described to you what happened in India, because we had exactly the same thing in Brazil: shortage of ICU beds, shortage of protection devices. And this in the beginning was really difficult for all of us. We can go to the next slide. So one of the first impacts of COVID-19, as we had in all over the world, was the fact that strokes didn't appear in our emergency department, especially TIAs. So we had no cases coming. The number of thrombolysis and thrombectomy really decreased in the first 3 months. In some hospitals, like in mine, like we had 83% less cases. And of course, we soon realized that it was not because strokes were not happening, unfortunately, but because they were at home. And I guess that the campaign that you, Valeria, participated of Stroke, Don't Stay Home was very important for us to teach our population that although we are facing a public health emergency with COVID, we still have chronic diseases and we still prepare to treat such diseases. So this is a publication of a group in Joinville, so southeast part of the country, but we have the largest largest registry for neurovascular and cardiovascular disease in the country, called the JoinVasc. So they evaluated the admissions due to TIA, stroke, and hemorrhagic stroke, and you can see how it decreased in the first 3 months was actually striking. We can go to the next slide. So very soon, in the first semester of 2020, we got together with the Society of Neurointervention, and we wrote a guideline in order to have the orientation on how patients with suspected stroke should be treated in the setting of COVID-19. So just as a summary, we suggested that some patients where at the beginning we don't have the ability of testing patients with RT-PCR. So we advocated that these patients, when COVID was really suspected, should be undergoing a CT scan of the chest in order to find out specific partners of COVID-19. And of course, to make sure that such patients were going to be treated in a protected stroke code, protecting not only the other patients, but also the healthcare professionals, because we did have a shortage of healthcare professionals in the beginning, and we still have having problems with that. So that was published very early, and it helped a lot, many hospitals to get their services organized. You can go to the next slide. So another worry that we have was to characterize the strokes that we are having together with COVID. So early on, we learned that this disease is not only a pulmonary disease, so it is a systemic disease. It does affect the coagulation system. It gives you a lot of inflammation. So we set a registry that was led by Dr. John Briner de Andrade, who you can see the picture here. And now we have 242 patients that were characterized in this national consortium of patients that had stroke in the setting of COVID. So basically what we are seeing since the beginning of the pandemics is strokes. They are not very young patients. So we are seeing strokes. The median age in our consortium was 65 years old. There was we've been seeing severe strokes, so maybe because the very mild strokes are still not coming, although we have been involved in trying to teach the population that they should really come. So the median NIH stroke scale in our series is 12, and they are coming late. So we're still having some problems with that. You can go to the next slide. So as you know, Brazil is a continental country. We have 200 million people, and stroke is still the second cause of death in our country. So, and the median stroke onset to the hospital time has been 900 minutes in our consortium. So patients have about 12 days from the symptoms from COVID. So they are basically at the end of the COVID symptoms when they are presenting with stroke. We've been seeing some hemorrhagic stroke. Of all those patients, we were happy to see this. We have 22% of the patients treated with recanalization, either thrombolysis or thrombectomy, but this can be a bias because we are basically collecting data in tertiary hospital. We've been seeing some more hemorrhagic transformation. 11% of the stroke patients had hemorrhagic transformation when they were associated with COVID, and 6% of the patients did have seizures. You can go to the next slide. So, and the outcomes, so specifically for ischemic stroke, we've been a little worried because mortality has been higher. So you can see here that we have more than 30% of mortality when the stroke was associated with COVID. And we had a significant number of patients staying with a modifying ranking scale of 5. You can go to the next slide. So another topic that I wanted to address is the impact of stroke upon clinical trials. So about COVID, the impact of COVID upon clinical trials. So this has been a challenging all over the world, and I wanted to give you this example of this trial that I'm leading together with Dr. Otávio Berwanger, who is a cardiologist. We are now with more than 3,000 patients included in the Utmost Stroke trial. So that's a trial that's trying to define what's the best systolic blood pressure after a patient has ischemic stroke. And we were really impacted by COVID. So ambulatory trials, patients that are not in the hospital didn't want to come to the hospital. So we had to write an amendment to the trial. And you can see here that we were happy to say that we are still able to continue the trial. So we are now the trial of the biggest number of patients, including lowering blood pressure after ischemic stroke. But I guess that we should be thinking about this from now on, because such trials, they still they are important to happen, even in the setting of pandemics, and you should be prepared to decentralize trial and to be able to conduct clinical trials in the setting of this emergency health problem. Can go to the next slide. So just concluding, I think that we should be really careful, because chronic diseases like stroke and MI are still happening even in the setting of COVID. It's very important that we know that COVID has the impact of activating the central nervous system, and it does can increase the possibility of having a stroke. So we have to have a lot of attention in patients with respiratory syndrome. And of course, we should be addressing the fact that we have to have new designs for clinical trials in order that you can still be treating chronic disease in the setting of emergency health public systems like what's happening with COVID. Thank you very much for your attention.
Thank you, Giselle. Very enlightening, very interesting. And we will discuss everything at the end. So now we will move to another continent, to the US. And I will ask Peter Panagos to present his data on the impact of in the United States. So thank you very much, Peter, for joining and sharing with us your data.
Thank you very much, Dr. Casso. It's certainly my pleasure to be here today to really tell a story that I think we're going to hear as a shared story across international borders, that we all have different resources and different challenges, but I think the story ultimately is the same story. It's a story of people doing their best to provide the best care under difficult circumstances. And I don't pretend to speak for everyone in the United States. Everyone has their story on how they have managed COVID and managed COVID in the setting of stroke and other diseases. But I think there's some general themes that I want to cover today that will give kind of a sense of what we've done in the United States to address COVID and provide outstanding stroke care at the same time. Next slide. So this table presents the leading causes of death in the United States for the years 2015 to 2020. And this really kind of shows the direct impact of COVID-19 in the US. And according to provisional data in 2020, there are notable changes in the number and ranking of deaths compared to 2019. In 2020, COVID was the third leading cause of death in the United States, never before kind of tracked or part of the cause of death prior to that year, with an estimated 345,000 deaths attributed to COVID-19. And there are substantial increases from 2019 and 2020 in other diseases such as heart disease, stroke, diabetes, and Alzheimer's disease. And so far today, in a total pandemic in the United States, we've had nearly 750,000 deaths due to COVID-19. Next slide. So the story is how to address COVID-19 in the setting of stroke. And while much of the public and scientific knowledge has been disseminated from United States federal agencies such as the Centers for Disease Control, NIH, Health and Human Services, Department of Defense, it really is, I think, some of our professional agencies, many of which are represented on this call, such as the Heart Association, Stroke Association, that really is much of the main source for disease-specific information. Early on in the pandemic, we, from the Stroke Council, issued some basic guidance on how to manage stroke. We then came up with additional guidance on how to manage stroke within stroke centers. And as far as infection control and educational strategies, then we started to have some registry data coming with Get With The Guidelines and other registry data that started to really paint the picture of the experience on how patients were doing, which patients were hospitalized, and outcomes. Okay. And then we started to see some basic science and mechanistic thought behind COVID and stroke, and some very thoughtful papers were beginning to come out on the role of infection as a stroke risk factor and determinant of outcome in stroke. And there's many papers that have come out since this that looking at the role of COVID-19 as an inflammatory marker for stroke and other vascular diseases. Collaborative work between other societies really kind of took off. And I think that's one of the stories to be told for COVID-19, that multiple medical societies in countries were working together to disseminate best practice across the medical spectrum, across borders, internationally, so people could share from each other's experiences. And then, where I spend a lot of my time in the pre-hospital arena, we try to provide pre-hospital guidance on how to triage patients effectively from the point of care where they had their symptoms to hospitals where they would get outstanding care in the setting of a global pandemic. Next slide. So last year, just about this time, we had the International Stroke Meeting, which was held for the first time virtually, but it was very successful. And there were many themes. We dedicated a significant amount of time to COVID-19, as would be expected for this meeting. And some of the themes that came up is that, COVID-19 may increase risk for large vessel occlusion stroke. These are stories that are still being written and still being described. It may be more strongly associated with stroke than other viral infections, such as influenza. It may occur later in disease in sicker patients and be a marker for prognosis and outcome. Anticoagulation, the role in critical illness, particularly stroke, was starting to become prevalent, and that has really kind of waxed and wanes over the last year. We've seen COVID-19 been attributed to cognitive decline in some patients, and certainly folks in the vascular neurology space are looking at this very closely. And very importantly, and I think we heard this story from our other colleagues across the globe, that there was a drop in stroke incidence in the United States from 2019 to 2020 of 25% related to essentially fear of going to the hospital. Patients were still having stroke, but afraid to go to the hospital for contracting COVID. Next slide. So what are the indirect impacts in the United States? I think this story is being written as we speak. We know that there's increase of death and prevalence in other diseases such as Alzheimer's, diabetes, and heart disease. We know that there was a fear of going to the hospital. So that has hampered early detection and long-term disease management and secondary prevention. We know we have increased in unintentional injury deaths driven by drug overdoses. As an emergency physician, I see this tragedy playing out every day. And interesting, and provisional life expectancy in the United States between January and June 2020 showed historic declines not seen since World War II years of 1942 and 1943. And then the mental health, educational impact, and developmental delays of our kids in school, I think, is something that we not have quite realized yet. Next slide. So where are we today in the United States? Well, variants. If we have to say one word that I think has crossed all borders, it's variants. And Omicron, B11529. These are rapidly circulating variants. And I just wanted to put this out to show and kind of let people know that are outside the United States what's going on within our borders. On December 4th, there were 99% Delta variants in the United States. Less than 1 month later, on January 1st, 95% of the cases that were tested were Omicron variant. This tsunami of cases, on January 3rd, for example, there were 1 million new cases of COVID-19 diagnosed in the United States. And this has tremendous impact to hospital capacity, workforce preservation, particularly in a workforce that's been challenged over the last year to provide amazing care in the hospital. So this leads to ongoing concerns such as flattening of vaccination rates, breakthrough cases in triple booster patients, asymptomatic carriers, insufficient testing available, and evolving CDC and federal guidelines. So the story for COVID-19 in a setting of stroke, in a setting in the United States, I think is a story that's still being told, but it certainly has tremendous impacts on our ability to care for our patients. Next slide. And everything I discussed will be referenced for you so you can look at this after the meeting. Well, thank you very much.
Thank you, Peter. Excellent talk. So again, we will have a round of discussion. So I will start with some poll question. I ask you all to vote. First question, you see what is the impact of COVID-19 pandemic in your country? Select one of the multiple options. Please go ahead. So we have reduction of the number of stroke patients, reduction of thrombolysis, reallocation of stroke unit beds, disruption of stroke rehabilitation, lack of availability, and other. Please go ahead. You can choose more than one, which is clear, then because it's not, nothing is exclusive. There's somebody who, they don't see the pool. Can you go forward?
Would you like to see the results? I'm sorry.
Okay. Okay. So I think the most important impact, which I can only confirm, was the number of stroke patients admitted. But there are a lot still to this technical support. Some people don't see the question. So if you can solve this. And there was also the reduction of rehabilitation, because we are almost focused on the acute care, but we know that that there is still a lot of to do on also on rehabilitation. Question 2, I hope you will see, everybody of you will see this question 2. So are there consensus and guidelines for sustaining the stroke system care in your country and region? Yes, no, uncertain. Please answer. Okay, it seems to work now a little bit better. We have the yes, wonderful. This is a good, very good result. So more around 70% of all the participants have some guidelines, which is good. I think this was also the fact that we were extremely active in this period. Everybody of us, we shared our knowledge, we discussed, and this helped a lot, the setting up the guidelines. Next, please. Oh, sorry. Now we pass over to the moderate discussion. So I ask all the participants to turn the camera on in order to ask you some question. So before I go forward, first I want to ask the question that we got from the audience, and there was. The first question is from Alison Schultz. She is asking, my hospital, we are currently seeing a huge increase of pulmonary embolism and DVT, those who are positive with COVID, as we are seeing with the increase of stroke in those who have previously tested positive. Have you something like this, observed something like this, Gerard?
Yeah, so in the first wave, we saw many patients like this with multiple problems. They would have had PEs or DVT, and also most of these patients had multiple comorbid conditions, hypertension, diabetes, and so they also had stroke. And even I remember one of the patients who underwent mechanical thrombectomy. They were able to retrieve the clot, but again, within 15 minutes, there was reocclusion. So it was a systemic problem where increased tendency for clot formation and all over the body.
Yeah, and there's another question about the shortage of the PE, about the N95 mask in your countries. Did you experience something like this? Who wants to answer? Giselle, maybe?
Valeria, if I just can add to what Gerard just talked about PEs and DVTs, I guess it was in the beginning, everyone was really, really afraid, because we were seeing those patients with very severe diseases and with very elevated D-dimers. and everyone was thinking, let's anticoagulate them fully and try to prevent complications. So I just wanted to make sure that we now have good clinical evidence based on clinical trials. Actually, Dr. Renato Lopes, who is a cardiologist from Brazil, works at Duke University, led the ACTION trial that compared full anticoagulation versus prophylactic anticoagulation in patients with COVID, and didn't show any difference. So although we've been seeing elevated D-dimers, they are prone to thrombosis, but there is no reason for us to be anticoagulating fully such patients, because we've been seeing also hemorrhages, including hemorrhagic stroke. Yeah, so we still have to find a better way to treat such patients, but it's not with full anticoagulation for everyone.
Absolutely, absolutely. So regarding this shortage, I think you can answer everybody of us can answer. We had, I think, some, not dramatically, but it was sometimes challenging.
Yeah, I think it was largely in the first wave in India, but in second wave, people were able to adapt, and there are many philanthropists, like in many hospitals. They came voluntarily and they donated the PPE kits, and so the first wave was learning curve for all of us, and then slowly the systems adapted.
Yeah. Peter, do you want to add something?
I would share the same experience. I think, just addressing the PE, and I think the question was the PPE, if I'm heard, so, I think early on, a lot of these patients are sick with comorbid illnesses, and are increased risk for thromboembolic disease to begin with. And these newer variants, we're seeing younger vaccinated patients with less likely to have these complications. But they, for their sicker patients that with underlying issues, we still see this, and we still address and manage these patients as if they had COVID or don't have COVID. So it's still the same treatment. As far as PPE, I think early on, I think a lot of the challenges in the stroke system of care and the unknowns prior to availability of vaccines was, what we were using, was it adequate to protect ourselves and our staffs and our families who we'd go home to some nights and many nights from contracting COVID-19 with an unknown outcome. So I think, as hospitals and systems and nations struggled to stockpile this, and we all gain our comfort level on what we needed individually to feel comfortable taking care of sick patients, I think the comfort level across specialties, I think, really increased, and I think the care became a little bit more seamless as the pandemic went on.
There's another interesting question about from Byron Merritt about did any area of the globe see younger patients with COVID having stroke? So is there especially young patient, let's say, being, as you mentioned, maybe Giselle, being COVID really the cause of stroke, not to be in a comorbid patient that you can have an additional risk factor that lead to stroke, but we have already a high level of conventional risk factor. Do you see especially young patients without no other risk factor having strokes?
I think I can start, Valeria. Yeah, we've been seeing, I guess, that there was a curve. So in the beginning, the many strokes that we saw were in patients with very severe disease who were in the ICUs for a long while, and then they got like a CT scan because of other reasons, so including young patients without comorbidities, and we found a stroke and we found a cerebrovenous thrombosis. We didn't see this increase in acute large vessel occlusion strokes. That's what it was described initially in the US. So I guess it's more, now I think it's as a coincidence. We do know that infection does increase the risk for stroke, including other infections, not only COVID, including sepsis and including influenza. So we didn't see as many cases without severe diseases, but we did see patients in the ICU with very severe disease, without comorbidities, that did got stroke, cerebrovenous thrombosis, and other thrombotic complications.
Yeah, I think I'll add to the same question. So we did a study where compared 3 months data pre-COVID 2019 and 2020, What we found was there was no difference in terms of age in both the cohorts. So it is not younger population that are affected. It is probably if the COVID disease is severe and they have comorbid condition, multiple comorbid condition, they have a higher risk of having a stroke. And yeah.
I think our experience was similar in the United States. I'm not a pediatric neurologist, but I think I share the experience of our other two speakers.
So there's also a request of commenting the secondary prevention. So it's something that on the impact of COVID-19 on secondary prevention that we always forget, because we need adherence, we need compliance, we need a setting of telemedicine and so on. I think surely you have to share something on this, because I think that we really see the impact of COVID, we will see it in 1 or 2 years. So we were very good in reducing the recurrence of stroke, but I'm not sure if we are still able to give the same care that we gave until 2019. So if you would like to comment, who wants to start? Maybe Peter this time.
Sure. Yeah, where I work in an emergency department, I see really the intersection of society and in the medical field, and I have for certain, and this is reflected by a lot of my colleagues' experiences, have seen many patients who have foregone they're using their long-term medications, their insulins, their antihypertensives, anti-lipid agents, due to either inability of access, going to the pharmacy, inability to purchase those medications. As a result, we are seeing presentations for severe hypertension, diabetic emergencies, DKA, other diseases, acute kidney injuries that are often preventable, but have occurred during this pandemic due to decreased access to outpatient care and pharmaceutical management of their diseases. So it's really, I think, a tragedy, but we've seen that, and hopefully that is getting better, but I'm still waiting to see.
Gerard?
Yeah, in India, we had a similar situation during the lockdown, the availability of medication for the patients. But I think for some of these medications, there was a time slot that they had given, the government had given, and the will be open and for a particular time period, and so that they could go and get the medications. But the important prevention program that was affected is in relation to cardiovascular diseases, the non-communicable diseases program at community level, where the frontline health workers could not go to their homes for screening, and also delivery of medication at grassroots level in the rural areas. It was severely affected. So the national NCD program was affected at least for a couple of months, and then slowly picked up.
Okay.
Yeah, I guess, Valeria, that's what we call the collateral effect of COVID. So I wanted to talk about the clinical trial, but this was approved also in secondary prophylaxis and all the clinics. Patients just didn't come, so they were not taking their medication. So it might be a reason why we're seeing more strokes, not only because of COVID, but just because they are just not doing what has to be done, to prevent stroke recurrence.
No, absolutely. I strongly believe this. I always say, because you fight to maintain the high attention to the stroke care. And I always tell all my, let's say, politicians and so on, please, we have to fight the war of the pandemic, because then there will be the part after. You have to be ready for all this undertreated patient, because this will be a huge impact. Psychologically, non-communicable disease, they will come back, and it's absolutely something that we need to be ready. So, and regarding, for example, you mentioned already, Giselle, regarding the Don't Stay Home campaign, there's a question about this great campaign done by WSO. So I think if you can share it a little bit more.
Yeah, I guess that in the beginning that was a high impact. So everyone closed at home, so really afraid about coming out. We know that social distance is important, but it's very important that the population, that we work with the population for them to recognize signs and symptoms of stroke, and to know that not only stroke, also, situations like MI. So in that situation, there is no way that the patient can stay home. So there's a lots of changes of mortality and of decreasing the ability of giving the best treatment that we can do. That's reperfusion. Here in Sao Paulo, we had the data of a higher number of patients dying at home, not of COVID, but of probably strokes and MIs without going to the hospital, and that's definitely not the way to go. So I guess that was a very important campaign. I think it did work. So we've seen after here in Brazil, after April, May, that we had again patients coming to the hospitals, and I guess that some of that was because of this increasing knowledge on the population of the importance of seeking for healthcare when we have acute diseases.
Gerard?
Yeah, so I think at the same time, we also had the same campaign in India, and it was widely publicized, and particularly in the national TVs. So we were able to see some improvement in presentation of patients to the hospital. Slowly they gain confidence, and that it's not very unsafe to come to the hospital with other illnesses. And so it really worked, that particular campaign. And
Peter, you as an expert of pre-hospital care, so I think you are a key member of this panel. It's very important. We cannot work without you.
Thank you. Yeah, it's certainly our pre-hospital providers who early on we're fighting the challenges of the unknown. If we did not have a lot of information in the hospital, certainly our EMS colleagues going to patients' home in the community with inconsistent PPE, with a lot of unknowns. I think truly that we're heroic and still are in many ways in how they manage our patients in very challenging environments. So, as those of us who are hospital-based wanting to provide our pre-hospital providers the best information and guidance on how to protect themselves as they're taking care of other patients, because, I think some of the questions in the chat allude to that the stresses on our healthcare provider workforce over the last 2 years are, I think, historical and unprecedented. And a lot of the challenges we're seeing, at least in the United States right now, in pre-hospital care and hospital-based care, are due to attrition, due to fatigue of healthcare workers. And currently, right now, with the Omicron variant, number of staff, just due to the transmissibility of the virus, of healthcare staff being out sick on limited quarantine until their symptoms resolve. So so our pre-hospital providers are truly the cornerstone of our system of care. So we have to do everything we can to keep that part of the system of care intact.
Yeah, I think this is a very important point. We always forget to speak about us as healthcare provider, and we are as much involved as the patient, because we are supposed to maintain this high level of stress. And it was not only for 1 month, it was for 2 months, it was then for 1 year, now it's the 2nd year. So there are also some reports about the quality of healthcare provider, let's say how much the healthcare provider quality influence the outcome of the patients. So we have another question about rehabilitation. It's not a lot, it's a little bit out of our topic, but maybe you want to share something about your experience, how much it impact rehabilitation. I don't know who wants to add something on this.
Yes. Yeah, so our early experience with rehabilitation, in the first wave, we had few bad experiences. About a couple of our physiotherapists got infected and they had to be quarantined. And and then we did not have any staff, to deliver rehabilitation. And so it was neglected. Everybody was focusing on acute care, and then we completely forgot the rehabilitation part in the hospital. So then we took measures for protection, and then we gave them they should not be continuously exposed to the patients. We involved the caregivers, and then as a national effort, the government of India allowed us to use telemedicine with a proper telemedicine guidelines. Till then, we did not have a national policy on telemedicine. So that really helped us to follow these patients at home, with video calling. And so that is how we learned through the COVID, the tele-rehabilitation.
Yes, absolutely. Is there anybody who wants to enter, who wants to add something on this?
I guess that just talking about telemedicine, Valeria, I just wanted to share what happened in Brazil. So in Brazil, we had a legislation that was very, very strict to telemedicine before the pandemics. And I guess that was at least a good part of it. Yeah, so everything was easier, laws were approved, and telemedicine was incorporated because there was no other way that we could care for patients without they come into the hospital without using telemedicine. I think the advances of digital health during the pandemics, it's something that's going to be forever. Yeah, I guess that we completely changed the way that we're treating patients and that we are caring for patients, and also that we are seeing patients in clinical trials as well.
I absolutely, telemedicine, it's now in our DNA, let's say like this. Also, do you see something with, which is going on artificial intelligence, for example, for CT learning, recognizing this, what we, for example, virtual assistant, something like this? There's a lot of discussion in our hospital how to use this new tools in order to protect the physicians, support the physicians, and also there's one question about in the chat about the shortage of physician nurses, because many left this job because it was too stressful. So to use artificial intelligence to support our daily work in such a situation, and also for the future. Peter, maybe you want to start on this?
Yeah, certainly in the, I think one-to-one in nursing, I think, is always going to be a personal in-person profession. And I think that's going to be difficult to kind of outsource to artificial intelligence. But I think we can be innovative in many ways on how we use technology. And, certainly, video access inside rooms of high-risk patients on nursing units, of COVID units that really that nurses have to kind of gown up and then clean down each time they go in and outside the rooms. I think using technology to facilitate care and connection with patients, I think, is important. Other ways where you're using artificial intelligence that I think are facilitating stroke care in many centers in the US are some of our newer imaging platforms that are able to get multimodal imaging fairly quickly, analyze for ischemia or infarct or LVOs, and share that with a large stroke team in order to mobilize resources much quicker. So I think that's something that's happening real time that has impacted stroke care, and that's just one small example.
Yeah. Jaresh?
Yeah, in the area of stroke rehabilitation, there are some technology groups. They are looking at developing movement-based and sensor-based AI technology for stroke rehabilitation. I saw some of the products in our Indian Academy of Neurology conference, which was held in December, and they're very good. If they, it is more of a self-directed therapy, and the patients can look at it, and the app can monitor the movement, and it can correct the movement also. And if the movement angle is not correct, and the information is given to the patient, this is not correct, and they correct themselves. And so I think COVID has really opened up research, particularly not only in the acute stroke workflow and imaging, but also in rehabilitation as well.
Yeah. Giselle?
Here in Brazil, Valeria, we still have a deficit of rehabilitation. So stroke services are much more organized for acute stroke care, but not for rehab. So definitely having opportunities to have technology in order to improve rehabilitation using telemedicine that can be cheaper and can give access to more people to be very important. We still have a lot to do regarding rehabilitation in Brazil.
Yeah. So let's say now from artificial intelligence, which is, I think, absolutely will be the future, but let's finish about some low-cost intervention you did in order to improve stroke care in your country. So to say also, look, it's not, as I said from the beginning, stroke is us. Stroke unit care, stroke care is us. It's not the high tech. It's our knowledge, it's our skills. So what did you do in order to improve stroke care at a low cost in your settings? So let's start by Peter, then Jerry, and then Giselle.
Sure. I think early on in the pandemic, with a lot of unknowns, we did several things. One, I think we increased the responsibility of early triage assessment of stroke patients to the emergency physicians and nurses to triage patients, whether they would be candidates for IV thrombolysis or mechanical thrombectomy, a little bit more than traditionally we had relied on. We used, in order to reduce exposure to our consultants and neurologists, used videos and an iPads technology to reduce exposures inside rooms of patients who were considered COVID or under consideration when we didn't have quick testing. And I think we ensured that everyone who had contact with a patient who was potentially infectious felt comfortable with their PPE. And I think that kind of looking out for each other early on, a multi-specialty, multi-collaborative type way, I think allowed us to treat our patients in times where our door-to-needle times and door-to-groin times were as good as they've ever been, just because we were very focused on the mission. So I think that's some of our early experiences.
I think, Giselle, you should, because I don't say Gerard, so maybe you can answer before.
In Brazil, everything that we initiated in the beginning of the pandemic had to be low cost because we are a low middle income country. So we did use low cost technology in order to discuss clinical cases. So early on, Dr. Sheila Martin published the use of the applicative called Join. So that's an applicative where you can see images at the real time, and then we can chat. And then because of that, patients, the staff were not all in the hospital, so we could discuss it from home, having only one person in the hospital. So that was, we're still using it because we did use for clinical trial as well, for the resilient trial. And this, the validation of the decision to thrombolyze with this applicative is published in Stroke. So that was something that we did in the beginning. Simple things, Valeria, like using, I guess that in the beginning, one horrible thing was that patients were admitted to the hospital for weeks and they couldn't see the faces of the doctors and physicians. So we did use, we did make sure that we had our names and our pictures very big when we were seeing the patients. So, and then sometimes like 1 or 2 months later, they would recognize us by this. So that's cheap and that's important. And that's patient-centered care, I think. And regarding clinical trials, for the OPNO trial, what we did was to provide patients with blood pressure monitoring. So the patients didn't have to come. It was actually cheaper than having the patient and the PPEs, and the patient always has to come with someone. So coming to the hospital. So that was some of the things that we did in the beginning, and we're still using them.
Thank you. Very enlightening. So, Gerard, you can conclude saying yours, and then
Yeah, I think
we are
my
done.
network, there is a problem.
Yeah. I think it's not
Froze
solved.
again. Yeah.
Can you hear me now?
Yes.
Yes, we hear you. Yes, yes. So I think in the meantime, so I already start to thank, and maybe when Jirash is again connected, then he can say some final words. So I would like to thank the World Stroke Organization and the AHA for ASA to involve us in this wonderful topic. And thank you very much. It was really great. And thank to the speaker. It was very enlightening for me, and have a wonderful day.
Thank you, everyone.
Yeah,
Thank
thank
you.
you.
Bye.
Be safe.
Thank you. Bye.